Welcome to Module 2, Public Health Palliative Care, the Compassionate Communities Model. Again, I'm Erin Collins, your trainer for this course. The Compassionate Communities Model of Care is the basis of all of our work at the Peaceful Presence Project and has really formed the belief in the end-of-life doula role, as well as utilizing community health workers to expand access and equitable end-of-life and palliative care. In this model, palliative care is really repositioned to support community-based health and social care for people at the end of their lives, meaning, as well as their families, meaning that there's community participation in the care and support of dying people and their families. This model kind of states that caring for one another during times of crisis and loss is not simply a task for health and social services, but it's everyone's responsibility, that each of us in the community has a role to play in supporting our family, our friends, our coworkers, our neighbors, as they navigate a serious illness, or they navigate the end of their life, or they navigate grief and bereavement and the loss of a loved one, or maybe even in the loss of a job or a pet. So this model really transforms the practices and the care that is provided, the conversations about death and dying and end-of-life care. There is a truly holistic and collaborative action between systems, and that's the healthcare system, the community, the local government, faith-based groups, churches, anywhere that someone lives, works, plays, or prays can be involved in this collaborative model of care. And because of trainings and skill development, and more education within communities, they are better able to provide skilled and informed practical and emotional support. This develops strong networks of care and resiliency in the community, and therefore makes that community stronger in providing care to one another. This all leads to higher quality and more equitable end-of-life care experiences with and without the presence of hospice and palliative care. One of the kind of foundational quotes is by Dr. Alan Kelleher, who was really one of the kind of founding researchers of this model of care. And he says that death is a social event at its core that has a medical component, rather than being a medical event with a social component. And we found a lot of this to be true with the birth, the idea of birth being a social event as well, and more home births, and doula involvement with births to ameliorate the intensity, right? And to address symptoms that can really be addressed by a social circle, rather than always relying first on medical interventions. So another tenet of the Compassionate Communities model is the 95-5 rule. And what this says is that only 5% of a dying person's time is spent face-to-face with a medical professional. And we could really expand that beyond the dying person to a person living with a serious illness. It's still 5% of their time spent face-to-face with a medical professional. Now, you might say, well, but what about somebody in the hospital? Or what about someone getting infusions? Sure, on a day-to-day basis, they are spending a long period of time, but over a week, it's still a lot of time not face-to-face. So the question in this model of care is, what are we as a community doing with the other 95% of the time? What is the quality of support that people are receiving, and from whom are they receiving it? Is it sufficient? And then we think about a lot of folks who live alone, or might be isolated, geographically isolated, and we have to ask, are they getting a good amount of support while they live with this illness? What about someone who's just lost their spouse? What kind of support do they have? And how can we as a community improve the quality of support that someone is getting? So as you heard in the beginning, it's also this compassionate communities model is also called public health palliative care. And that's because if you look at palliative care, if you look at serious illness from a public health perspective, there's a lot of things that come into play. Right? What social determinants of health need to be addressed for this person as they live with an illness? We think often of folks who are living unhoused at the moment and maybe receiving cancer treatment. How do we improve the quality of life that they have while going through cancer treatment by addressing their housing? Public health also looks at health promotion. So what if we were to reposition serious illness, aging, the end of life as topics to be discussed rather than something to be hidden away? Could we improve the way that someone faces a serious illness or faces the end of their life by giving them the opportunity to talk about it, by normalizing conversations? In the civic realm, how do we involve local policy and statewide policy to improve the way that communities have the ability to care for one another? And also looking at social networks, we look at what is the social in our psychosocial interventions. How can we improve the social circle around someone who is living with a serious illness? So when we look at this compassionate communities model, as you recall, I said that this is at many levels. And we can start with the individual level. And if we develop more compassion in ourselves, more of an awareness of our own relationship with illness and with death and with grief, then we become a more compassionate, we become better equipped to show up for someone, right? We're more mindfully aware. We're more attuned to what someone else might be going through. And we might start cultivating the knowledge and skills to really companion them through this illness. And compassionate individuals lead to compassionate relationships between family members, right? We might have more empathy for a family member going through a difficult time. More compassionate relationships between patient and caregiver, or patient and healthcare provider. There's more compassion between our team members. We work better together as a whole. Our organizations, right? The more individuals who are in better relationship then create better organizations, more compassion. And then there's more compassionate involvement of systems, right? We talked about this holistic collaborative action between systems. So if we look at the organizations themselves, developing this skill set of empathy and compassion and the ability to show up for one another leads to better policy and structural leadership. It leads to more guidance and accountability, and could truly lead to more economic sustainability for these programs. So from the individual to the relationship to the organization, we can then cultivate this compassionate community model, where there's more solidarity among and between us, where our attitudes towards illness, towards death, towards grief are more aligned and more aligned with compassion and aligned with the normalcy of these life experiences, with a shared value and a shared sense of belonging. Then these communities are just better equipped and more resilient in the face of so much illness, even in the inequities that exist in the healthcare system. We as a community can be providing a better level of support for our fellow community members. So specifically in Oregon, some of the things that we consider as social determinants related to serious illness and end-of-life care. And these determinants are true all over the place and are true outside of serious illness, but they exacerbate a person's ability to have a high quality of life when they are navigating an illness. Especially in rural communities, we see there's a real shortage of specialty providers. There's a shortage of primary providers, let alone providers who are trained or certified in palliative care and end-of-life care. Transportation is a significant issue. If you need to travel 3 hours to see a specialist, yet there isn't any way to get there, then that really creates a problem and creates an inequity in access to the care. Social isolation in rural communities, there are more individuals who live further apart from their neighbors, and that can lead to great psychosocial suffering for someone who is either living with an illness or has lost a loved one. Rural communities tend to have, or people living in rural communities tend to have more financial instability, and that leads to a difficulty accessing the care they need and want, accessing transportation, accessing food, accessing internet and technology. So internet and technology, telehealth is often touted as a solution to the shortages. However, if you are an older adult living in a rural community several miles from your nearest neighbor without transportation, and you are living with cancer or heart disease or COPD, there's a great deal of inequity in how you're going to access someone providing telehealth. So there is an opportunity, if there is internet available and connected in someone's home, a community health worker or an end-of-life doula who is has a great deal of technological literacy can be a great support and could increase the access to telehealth. That's not always true in rural Oregon, and so it does create that disparity. And so we have to say, what else can we do? How else can neighbors and friends and fellow faith community members step up and kind of fill in that 95% of the time and address the psychosocial, the emotional, the spiritual, and the practical needs, which are the greatest majority of what a person needs support with as they navigate a serious or terminal illness. So our organization, the Peaceful Presence Project, is trying to address the issues in inequities in care across Oregon. We have developed a statewide network for serious illness care. The first of our goals was training individuals as end-of-life doulas in rural communities. And I'll talk more about that and some opportunities. We've developed continuing education for community health workers to be able to provide all that non-medical palliative support within their current roles. There can also be some opportunities coming where there might be a specialty palliative care role for a community health worker. The second step within this network is really starting to establish peer-to-peer networks within each county, as well as a statewide peer-to-peer network where individuals trained as community health workers, as end-of-life doulas, come together on a quarterly or bi-monthly basis to talk about what's going on, what's coming up, what questions do you have, what is a best practice for this that I'm navigating with my client. We provide ongoing mentorship and support to encourage those best practices and to sustain this peer-to-peer network. We're also in the process of developing an online directory for end-of-life care practitioners. Again, that might be doulas, it might be community health workers, it might be personal health navigators, it might be healthcare workers or healthcare providers who are working on a volunteer basis and want to create this web of support within their community. This online directory will be a way for you to find each other. It's also a way for a healthcare provider, for a CCO, to find someone in a county who provides varying levels of palliative and end-of-life support. It's also a way for people who do have internet connectivity or a smartphone. They could go to this and look in their own community and find someone. Or a loved one who lives far away might be able to say, oh, there's someone in my mom's county who could support her while I'm not able to be there. This is a developing network. It's a long-term process. We have a 5-year plan, but we're really excited about the opportunities and hope that some of you will consider joining this statewide network. So the first opportunity to gain more skills is in palliative care continuing education for community health workers. Now, you don't have to be a community health worker. Any traditional health worker role can take this course. It's offered through Oregon State University's College of Health in their professional and continuing education program. It will occur in September and October of 2024. This course offers 12 continuing education units that if you are a registered traditional health worker with the Oregon Health Authority, you need 20 hours every 3 years to recertify or re-register. These 12 credits will count towards your recertification. The course is 4 weeks long, and it's about 3 hours of work each week. You have 2 hours of self-study and then a 1 hour Zoom on Fridays. In the course, you will gain a more comprehensive understanding of serious illness care. You'll learn more about the 8 domains of palliative care. You'll learn some practical support and communication skills, some non-medical symptom management that can be very helpful, especially if you're visiting someone in a remote area. You'll learn advanced care planning, how to support someone in completing an advance directive or doing an end-of-life plan. And talk more about community stewardship and bringing this network to your community and how you might better support and better do the outreach and capacity building within your community. The registration is not yet open as of the time I've recorded this course, but you can reach out to me by email, erin@thepeacefulpresenceproject.org, and I can let you know when registration is open. And just so you know, there are scholarships available. So if the tuition presents a problem, a financial problem for you, we have scholarships available. So don't let that be a deterrence. I also wanted to mention, it's not on this slide, but I also wanted to mention our end-of-life doula training that happens throughout the year. And you can also contact me, or you can contact info@thepeacefulpresenceproject.org. We have ongoing foundation-funded trainings for people living in rural Oregon. So if you live in a rural community, reach out. As of this recording, we have a course in the fall of 2024 for rural Deschutes, Crook, Jefferson, and North Klamath counties. So if you live in one of those counties, we'd love to have you reach out and apply to be a part of the program this fall. Together, we can make Oregon a model compassionate community state, and you can create your own compassionate community where you live. We encourage ideas, we encourage networking, we encourage you to get in touch with us and work with us to better support all the individuals in our communities living with serious illness and or nearing the end of life. This completes the audio for this module. You'll have another quiz, and so if you score an 80% or higher on both quizzes in both modules, you can look for a certificate in your email. You can retake the quiz as needed to reach your 80%. If you don't receive a certificate after scoring 80% or higher, you can reach out to OregonLearns.net through this learning platform or via email to get more information. Thank you for participating in this course and for your interest in palliative care and improving serious illness care in our state.